on the right, right? I'm going to talk to you today about paraneoplastic syndromes and autoimmune encephalitis and attempt to make a very simple, coherent roadmap for you when you're confronted with patients that you think might have this variety of organic brain disease. This field is largely dominated by neurology and immunology, and bless their hearts, they don't use the same language that we use. So when they describe psychiatric presentations in these patients, they don't use technical terms that you would understand. They use terms like altered mental status or confusion and other euphemisms for what we would call delirium or psychosis. And that makes it a whole lot more confusing to understand the literature and have a kind of straightforward approach to patients. My goal then is to describe to you a case that's illustrative of some of the core principles in assessing and treating these patients, and then generalize and go over the biology of autoimmune encephalitis and give you something that you can use as a template anytime you're confronted with this possibility. ER, consult liaison service, in the clinic or in the field after residency. So my goal is that by the end of today, you will have an understanding of the basic underlying biology, how it translates into clinical presentations, and can use that roadmap to assess patients, and also have a sense of the treatment options that are available for the immunologic component, and also some rules of the road in terms of prescribing psychotropic drugs to patients with these types of syndromes. So I'm going to start off with the vignette. Imagine you are the on-call resident for the weekend, and at sign out on Friday afternoon, you hear that there's an incoming medevac from Landstuhl of a patient who required 2-to-1 observation, IM Haldol several times, was in restraints, and they think is a great candidate to come to 7 West. And then the patient rolls in after 5 o'clock, and you find out that the CK was elevated. The patient sounds more like he has delirium than an acute psychotic process. He's confused. He's got problems with incoherent speech. He does not seem to be attending to the interviewer, and they thought he actually might have had alcohol withdrawal. So as a result of those concerning organic factors, the on-call resident decided to have the patient go to medicine for a while and be worked up for organic causes of change in mental status, and also get IV fluids, surveillance for alcohol withdrawal, and so on. So the patient was promptly transferred down to 5 Center and responded well to those kind of conservative medical management. The CK resolved. There was no evidence clinically of rhabdomyolysis. Neurology were consulted to ascertain the possibility of any organic pathology that might have caused the mental status changes. There wasn't much in the background history. The patient had no history of psychiatric treatment other than brief contact with psychotherapy for an adjustment reaction. His brother had been shot in uncertain circumstances on the streets of Las Vegas 8 times, and the patient had leave to go home to see his brother in the hospital recovering from his gunshot wounds. And in the context of that family circumstance, he'd had brief contact for counseling, but other than that, no psychiatric history, no antecedent medical problems, otherwise fit and healthy military police officer. Clinically, neurology thought he had signs of catatonia. They performed a lumbar puncture and ordered a whole host of diagnostic tests, most of which were negative, but salient positives. There were 2 things. One was on MRI in Landstuhl, and again here, there was a single focus of T2 hyperintensity in the white matter in the frontal lobe, pretty non-specific, not a particularly large area, but just notable that it was there. And most significantly, had elevated white blood cell count in the CSF. I think his total white cell count in CSF was 79, and it was predominantly lymphocytes. All the tests for esoteric pathogens, fungal, and so on were negative. The neurology started to form an opinion that this might be a paraneoplastic syndrome, and so did a whole body CT survey to look for tumors, which was negative. On 5 Center, he was pretty hard to manage for the nurses. He was hypersexual, he was combative, He was extremely unpredictable. He had periods of essentially being mute and having very little motor activity, and then he would become very excitable, typically in the middle of the night, and engage in running around the hallways naked, combative behavior with staff and other patients, yelling, screaming, singing, chanting phrases over and over. And they petitioned to have him come up to 7 East, so we brought him up for ongoing management. Initial mental status exam is documented there, and I'm not going to read the whole slide, but he had a number of significant abnormalities. He was pretty resistant to the idea of wearing any clothing, which was consistent throughout his stay. He had echolalia and echopraxia, so he would copy or mimic the statements or the motor behaviors of his interviewer. Was profoundly thought disorder, so the form of his language was fragmented, often incoherent and nonsensical, repetitive phrases or repetitive lines of a song. And most importantly, he had evidence of cognitive impairment with fluctuating levels of alertness. And when he was impaired in his alertness, he was also inattentive. So the first and second year residents here will remember me harping on this. In patients with acute psychosis, the cognitive exam is the most important part of the examination because there's a widespread differential for acute onset psychosis, but cognitive impairment with psychosis is a different diagnostic category than patients who are cognitively intact with psychosis. So he is cognitively impaired with psychosis, implying this is something in the organic domain. He's got some type of pathophysiologic process in the brain, which is impeding consciousness and global cognitive function. Neurology had already tapped him and sent the workup with a paraneoplastic antibody panel. And a couple of days after he was on 7 East, that result came back. He was positive for antibodies against the NMDA receptor. So the working formulation was that he had NMDA receptor encephalitis, and they recommended aggressive immunotherapy, which we executed with cyclophosphamide, and then he had 4 infusions of rituximab, which I'll talk about in a little bit. He improved significantly. He went from being essentially unable to cooperate with a mini mental status exam or being non-responsive to questions to scoring 22 out of 30 when he had completed the rituximab course and the cyclophosphamide. But then about a week after the rituximab ended, he became floridly manic. And he became so behaviorally unstable, we had to have him on 2-to-1 observation, and he was requiring frequent IM, sedative, B52 interventions. When we weren't on top of his behavior, he would get a hold of a cell phone or one of his colleagues' cell phones, and he was on the phone trying to buy expensive items, particularly automobiles and motorcycles, television sets, and giving money away to family. High pressured speech, decreased need for sleep, markedly accelerated movement, some hypersexuality, and again, this consistent theme where you don't need to wear clothes in a hospital or around other people. And it was a colorful time on the unit. He was pretty hard to manage. We ended up treating him with a combination of valproate and quetiapine. We chose those agents because you can essentially go from 0 to max dose very quickly. So, you can load people with valproate and get them on a couple of thousand milligrams in the first 24 hours, and you can hit people with 400 to 600 milligrams of quetiapine straight off. And that's what we did. His behavior responded, and then he would have exacerbations where he became hard to manage again. And ultimately, he refused to take meds. So at that point, we were forced to transfer him to 7 West to pursue involuntary hospitalization and get a mandate to involuntarily medicate him. So we sent him down the hallway, and he was committed for a while. He went through the Boxer process, and he was on 7 West for a while. I'm going to come back and pick up on what happened with this patient in the second half of his stay. But I want to dive into the biology of autoimmune encephalitis and talk about the history of the condition and how to understand what this is from a pathophysiologic perspective, and then weave that into a clinical algorithm that you can use when you assess patients. So in the 1960s in the UK and Europe, there were a number of studies, and these are two classic papers from the 60s, that looked at small series of patients who had small cell lung cancer or teratomas, ovarian teratomas, who developed neurological syndromes that were characterized by significant amnesia or memory loss, seizures, and intermittent delirium. And then when the patients died, they did postmortem brain histology and identified that there was inflammation in the limbic system. So this is preceding our ability to do CT scans or MRI, but the autopsy showed consistently this pattern of limbic encephalitis. And this spawned the whole field of paraneoplastic neurology, the idea being that you have a tumor somewhere in the body which does not spread to the brain, but through some mechanism impacts brain physiology and causes brain inflammation. And this was the basis of a subsequent large series of single case reports and a few small case series where this phenomenon was repeatedly described, that cancer patients with certain types of tumors had likelihood of developing these neurologic syndromes, which were typically marked by delirium, seizures, sometimes psychotic symptoms, and occasionally movement disorders. The theory was that these patients were symptomatic because the immune system had activated against the tumor, but the tumor was expressing some embryonic antigen or an antigen which was also expressed in the brain. So the immune system targeting the tumor was cross-reacting with brain tissue. A physician at Cambridge in London in England took this hypothesis a stage further, Newsom Davis, who said, well, if that's the case and these patients are developing antibody responses, we should be able to remove their circulated serum antigen antibodies and mitigate the immune response. And can you skip forward 2 slides? So that's what happened. They essentially road tested that theory. So in this particular paraneoplastic syndrome, which is called Lambert-Eaton or Eaton-Lambert syndrome, patients have a small cell lung cancer and they make an antibody against a voltage-gated ion channel that's involved in muscle contractility, and they get myasthenia from it. So even though the tumor is microscopic, they start to get proximal muscle weakness and fatigue because the excitability of the muscle tissue is impeded by the antibody blocking the ion channel. So the plasmapheresis protocol basically involves spinning down the blood, and in the centrifuge, the cells spin out and you give them back to the patient, and the rest of the plasma gets deposited in the waste, and you replace the plasma with some colloidal solution that is the same osmotic constitution as blood. So you give them back their cells and you've removed all the antibodies. If you can jump back 1 slide. So that intervention in these cases was effective, and this was recognized as confirmation that there's some type of circulating immune process, presumably antibody-mediated process, that is triggered by the tumor and then acting on remote tissues. And that became the basis for the sort of hardening theory that the paraneoplastic syndromes were caused by immune reactivity to tumors that then cross-reacted with brain tissue. Now, what that meant was that every patient was then thought to have a tumor somewhere. This type of syndrome was 100% linked to the presence of malignancies. And the idea was if you see a patient who has a presentation of the kind I described, if you can't find the tumor, sooner or later it's going to pop up. Over the next 20 years, the field has evolved, and we now recognize that roughly 50 or 60% of patients are not going to have an occult malignancy. So what's changed in terms of the biological understanding of the process is that we now know that for some reason, patients will generate immune activity against brain tissue without a triggering occult malignancy. The triggers can be viral infections, particularly herpes simplex virus. So cerebral or encephalitis with herpes, about 20% of patients will have a post-infective episode syndrome, which is basically caused by the virus, destroying the cell membranes and allowing antigens to leak out and be visible to the immune system, and then you then have a late immune response to the viral infection. One result of this evolving theory of what the syndrome is that the language then changed from paraneoplastic syndrome, implying you had to have a neoplasm, to autoimmune encephalitis, which is a broader term, recognizing that these patients are symptomatic because an immune activity is going on against brain tissue, but not pinning it on the presence of a malignancy. And that's where we are now. Essentially, a better term to use in these cases is autoimmune encephalitis or antibody-mediated encephalitis. And that encompasses those patients who are going to have an identified malignancy triggering the immune response, but it recognizes that 50 to 60% of patients who don't actually have a malignancy and there's some other etiology. It might be a viral infection, but for a substantial minority of patients, you never find an explanation for this. They just spontaneously develop this autoimmune disorder, and the mechanism is it's immune mediated, it's antibody. So I'm going to fast forward through a couple of decades of immunology and molecular biology and kind of give you the punchline of where we are in understanding what causes this group of disorders. There are two mechanisms immunologically that the brain gets damaged by your immune system. One is antibody mediated, and that pertains to surface antigens. So some of the autoimmune disorders are straightforward, easy to understand processes where an antibody is binding to a cell surface protein on a neuron that then impedes the physiology of that neuron. The target antigen might be a calcium channel or a potassium channel or a receptor, for example, for GABA or glutamate, which are the commonest ones. There are also a number of autoimmune reactions against intracellular antigens, and those are harder to explain. They can be intranuclear antigens that are transcription factors that are involved in gene regulation, or they can be in the cytoplasm. It's not clear that the toxicity from the immune activity is antibody mediated. It's probably cytotoxic T cell mediated. And I'll just elaborate on that a little bit. So before I go into the biology of that, just to summarize the nosology, we started with paraneoplastic syndromes really because of limbic encephalitis, which is one form or one flavor of autoimmune encephalitis. Over time, we recognized that some patients develop this type of disorder without a tumor, and we evolved to using the antibody-mediated encephalitis or autoimmune encephalitis. And now we're recognizing that not all of the syndromes may actually be mediated by antibodies. They may be mediated by T cell activity. Examples of specific syndromes, there are literally dozens, and probably end up going to be more than 100. There's going to end up being more than 100 syndromes which are in this category. And where we are currently is we're consolidating all these different syndromes and trying to pull them into one categorical group. It's kind of like the old days when psychiatry 100 years ago, we're understanding that patients had delusions or hallucinations. We used to have names for specific types of delusions or specific types of hallucinations. So I remember when I was training, people would talk about Charles Bonnet syndrome or de Clerambault's syndrome, which basically pertain to one particular type of delusional idea or one particular type of hallucinatory experience. And they have very little diagnostic value. It's a whole lot of memorization for the boards that you don't really need to know. Basically, you just need to know that patients have hallucinations and delusions. The same thing is going on with autoimmune encephalitis. There are a whole host of named syndromes like Hashimoto's encephalopathy, for example, which is associated with thyroid disease. It's an autoimmune encephalitic process that happens to associate with thyroid disease, or NMDA receptor encephalitis, or limbic encephalitis. These are basket terms for subcategories which may be associated with specific types of autoantibodies, but they're all the same in their phenomenology. It's autoimmune activity against brain tissue. And there has been a good amount of molecular immunology over the past 20 years, identifying all the different antibody types and all the targets for the antibodies. And to some extent, the different antibodies do define different syndromes. I'm going to just kind of, in sweeping generalized terms, give you a couple of examples of that. GABA, which you know is the major inhibitory neurotransmitter in the nervous system, antibodies that block GABA receptors are associated with seizures, which makes sense, right? If you upset GABA physiology, for example, in alcohol withdrawal or benzodiazepine withdrawal, the risk is withdrawal seizures. So anti-GABA antibodies are frequently associated with seizures. Limbic encephalitis, glutamate-mediated autoantibodies are associated with amnestic syndromes because the limbic system is involved in short-term memory. So those patients frequently have A, psychosis, and B, very profoundly impaired memory function. And some of them end up with a chronic dementia syndrome with memory impairment. But the list is burgeoning, and the number of syndromes is mushrooming with the list of antibodies, and they're not stereotypical. What you'll find people with NMDA receptor encephalitis that have seizures, and then another patient won't have seizures. You find people with a GABA receptor antibody, but they won't have seizures. The majority will. So they're kind of loose associations where you can make majority intuitive assertions, but they're not hard and fast. And clinically, it's not really that useful. And kind of just abstracting out of all that science, I would say, just recognize that there are a whole host of different autoantibodies. And to some extent, they have stereotypical patterns. But the bottom line is these are autoimmune mechanisms that damage brain physiology. There's some structure function correlation depending on which part of the brain or the peripheral nervous system is affected. But the bottom line is these are autoimmune disorders where there may be a malignancy, there may be a preceding viral infection, or there may not be an identified antigen trigger. And the primary mechanism of action is autoimmunity. The primary treatment is immunosuppressant therapy. This is the most recent slide I can find that's listing all the current autoantibodies that are identified as associated with autoimmune encephalitis. And one thing that's important to know about this list is when you order the test, whether it's the Mayo Clinic or ARUP, which is the private pharma company that does this, you maybe get 8 to 10 antibodies. So there are dozens of antibodies that you're not going to get in your testing panel. And you will frequently find yourself in the circumstance where you order the test and it comes back negative. And it doesn't mean that you don't have an autoantibody, it just means it's not in the testing package. So this slide's a little complex, but let me just try and go through the basics. So T cell and B cell autoimmunity. B cell, easy to understand, there's an antigen presented to the B cell precursor. You make antibodies through clonal selection of that particular clone of B cells. You make a whole slew of antibodies that then circulate and target that antigen. The T cell autoimmunity is a bit more complicated, and it looks like what happens in T cell autoimmunity is that you have to have rupture of the original antigen containing cell. So when you have post-viral or paraneoplastic syndromes where there's a tumor cell that's leaking an antigen or a virally infected cell that's leaking the antigen, that's much more likely to be a T cell mediated immune response where the cell is damaged. The original cell that contains the antigen is damaged because the tumor physiology has corrupted normal cell function and apoptosis, and the cell dies and leaks contents into the blood that shouldn't normally be visible to the immune system, or the virus ruptures the cell membrane and disrupts cell physiology. And those fragments of the antigen get picked up by your T cells and processed and presented, and you end up with a cytotoxic T cell response. So put another way, in circumstances where the target for the immune response is inside the neuron cell, so it's a neuronal cell enzyme, or it's a nuclear protein, it's much more likely that the trigger was a tumor or a viral infection, because intracellular antigens have to come from damaged and leaky cells, so you need a process to do that. The pure antibody mediated, often the idiopathic syndromes, are much less likely to be associated with malignancy. It's not a hard and fast association, but it's a good generalization. In the antibody-mediated mechanisms, basically then you're circulating antibodies that will bind to a variety of different cell surface proteins that do important things in nervous system function. They are typically ion channels or neurotransmitter receptors. And when antibodies bind, it cross-links those molecules and they get endocytosed and they're inactivated. So the antibody basically disrupts the normal physiology. And most of those targets are either receptors for neurotransmitters or potassium or calcium ion channels or associated regulatory proteins that are required for those channels to work properly. All right. We have, in our case, an example of NMDA receptor encephalitis. I'll just tell you a couple of some common findings in patients who have that particular flavor of autoimmune encephalitis. There are significant male-female differences. The majority of female patients with NMDA receptor encephalitis have an ovarian tumor, particularly an embryonic molecule expressing ovarian tumor, a teratoma. Whereas male patients, well, if they have a malignancy, it's usually a testicular malignancy, but the majority of male patients do not present with an occult tumor. Of all the autoimmune encephalitides, this is the one that's most likely to show up in psychiatry, because these patients typically are floridly psychotic. They have bizarre behavioral presentations. They often have mania. They are usually psychotic. They may be intermittently delirious. Some of them have seizures. They frequently will show up in the emergency room because of an acute change in behavior and mental status. And the psychotic symptoms often drive the ER docs to refer them to psychiatry. And I think I've seen about 5 of these cases over the years now, and they can be among the most spectacularly behaviorally disturbed and manic people that you'll see. So the severity of the psychiatric disturbance is fairly impressive. Over time, the condition progresses and they get more cognitive impairment, which is typically short-term memory impairment. And most patients end up with a spectrum of symptoms, although they can have a protracted course where they have a monosymptomatic presentation. So they can have mania or refractory psychosis and they don't develop the cognitive syndrome, but the symptoms are almost always florid. The diagnosis is sealed by ordering the autoantibody, which is positive for the NMDA receptor. The world expert on autoimmune encephalitis, if you're interested in learning more, reading the literature, is Joseph Dalmau, who has a joint position in medical school in Philadelphia and in Spain. We actually consulted him on this case that I described to you, and I'm going to come back to. And he has written the best review articles. I'm going to show you one reference from him, who led a working group on consensus clinical practice guidelines and diagnostic criteria. But he is trying to pull this nosology into one coherent model. And I don't think they're quite there yet. But essentially, the idea is that autoimmune encephalitis or antibody-mediated encephalitis constitutes a group of disorders where patients have clinical symptoms because they are mounting an immune response to brain tissue that may have been triggered by an occult malignancy or a viral infection, and that typically those patients have a combination of presenting symptoms that can include mental status changes, and I use that term in a neurologic sense, so that encompasses everything from delirium to behavior disturbance to psychosis, along with movement disorders, autonomic dysfunction, which is an important thing to check for. So that means orthostatic hypotension, intermittent idiopathic tachycardia, sweating attacks, as well as changes in motor function. So new onset tic disorders or chorea or athetoid movements, that constellation of abnormalities. Many patients have a viral prodrome, and that's worth asking about. Fever, headache, malaise, just general weakness and not feeling well over the couple of weeks prior to presentation. Commonest viral infection triggering autoimmune encephalitis is herpes simplex virus. All right, so we've talked a little bit about the biology of this. So there's a portfolio of autoimmune mechanisms ranging from cytotoxic T cell activation to a whole portfolio of antibodies that target all kinds of cell surface antigens in the nervous system. How do you take this and approach patients? So I'm going to make some sweeping generalizations, but I think are some fairly robust rules of the road in terms of assessing patients. Now, I've said this to the PG1s and 2s in didactics, and I'll just repeat it. When I was a med student, my professor of medicine was a pulmonologist, and this was back in the UK in the 70s when everybody smoked tons of cigarettes. Not all the physicians, but many of the patients smoked tons of cigarettes and a lot of lung cancer. And he used to say, any young man that coughs up blood and has smoked cigarettes for years has lung cancer until proven otherwise. But just a simple, straightforward thing. You always assume people with hemoptysis have lung cancer, and you should rule that out before you consider other etiologies. Well, the take-home message I'm going to give you in the assessment of autoimmune encephalitis is every single case that you will see will have delirium. So of all the things that you can do in terms of CSF studies and neurologic exam and imaging, the single most important diagnostic index that you will look for, you should look for, is the presence of delirium. And that is invariably associated with this group of disorders. This is the last big group consensus practice guideline. I'm happy to share this. If people want this, just shoot me an email and I'll send you a copy of this article. But this is a multi-center working group that was chaired by Professor Dalma that has brought together kind of clinical practice guidelines. How do you approach these patients based on clinical symptomatology? What do you do when you can't get the antibody studies back for a month? And how can you decide who you should treat with immunotherapy? And I'm going to distill from that kind of some general principles. So in most circumstances, you're not going to have the paraneoplastic or autoimmune antibody panel back. And you're going to have to decide what to do with the patient. There's going to be considerable pressure to do something because the patient's going to be dismantling 5 Center or the ER or driving the nurses crazy on 7 West, and people are going to want you to come up with therapy. You can't say, we'll just wait for a month till we get the paraneoplastic or autoimmune antibody panel back. There has to be an algorithm that you can follow to begin treatment. And the punchline is, it's a reasonable thing to start immunosuppressive treatment before you have a positive antibody test. In the circumstance where the patient meets these consensus criteria for possible autoimmune encephalitis, so just highlight a couple of things. So rapid onset of altered mental status. And I edited this slide. What they mean is delirium. So if you have a patient who has new onset psychiatric presentation and the clinical examination yields the impression that the patient is delirious, meaning they have impaired orientation, they are inattentive or drowsy intermittently, they have difficulty with recall, they have difficulty with praxis, they have trouble with naming, repeating, or obeying commands, and anything that lowers points on the mini-mental or the MoCA, that's highly suggestive that they're a candidate. Also important, any focal CNS signs, so that would be an index of some area of inflammation in the brain. New onset seizures, and certainly, I think you'd agree, would carry over the lines into organic brain disease, and CSF white cell elevation. And that's often the only abnormality on the CSF study. So you don't typically see elevated protein. You see elevated protein in red cells in viral infections and bacterial infections, but not in autoimmune disorders. And the CSF might be negative. MRI is positive in about 30% of cases. So the majority of patients, you're going to run a scan and you're going to get a result like we did in the NMDA receptor case I presented at the beginning, where there's maybe 1 or 2 T2 signal areas that might be normal or may not be a big deal. And I still wouldn't, in this index patient I described, wouldn't read too much into it. It's not, and it's a finding that in other patients would be unremarkable to the radiologist. And then that you're ruling out other potential etiologies like meningitis, or the patient's had a closed head injury, or they have a stroke in evolution. So if you don't find an obvious explanation for new onset psychiatric symptomatology, they're not using PCP or any psychoactive drugs, and they have these category of symptoms, then it's reasonable to start autoimmune therapy, first line therapy, and I'm going to define what that is, in advance of waiting for the antibody test. Yes?
What are the most common findings on brain MRI in these cases? Is it those kind of non-vocal consumatencies, or are there specific things that you would tell the radiologist to look for?
They correlate with the type of the type of syndrome. So limbic encephalitis, where you have medial hemispheric inflammation, you do actually see T2 signal intensity in the hippocampus and medial temporal lobe. Other syndromes, there is no pathognomic finding. If there's a finding, it's going to be patchy T2 signal intensity, suggestive of non-specific inflammatory changes. Sometimes they're spectacular, but more often than not, there's very little to see in the MRI. All right, so kind of pulling together the clinical phenomenology, I want to use this slide to hammer home the point. Psychotic symptoms, non-specific, multiple etiologies that range from psychiatric illnesses, bipolar affective disorder, major depression, psychotic features, as well as autoimmune encephalitis. And there are a whole host of other things, as you know, that make patients acutely psychotic. So the fact that the patient's psychotic is diagnostically not helpful. Catatonia is, again, diagnostically not helpful. You can have catatonia in schizophrenia, you can have it in bipolar disorder, and you can have it in a host of organic conditions, including autoimmune encephalitis. Behavior disturbance, and I'm talking about involuntary commitment, unsafe, or bizarre behavior level disturbance, again, is diagnostically non-specific. These are all things that impress the emergency room and our colleagues in medicine and surgery, and they will invariably consult psychiatry because patients are psychotic, catatonic, or have disruptive or bizarre behavior. But from your perspective, diagnostically not helpful. What is helpful is the presence of a delirium. So an acute change in cognitive function with disorientation, memory impairment, impairment in other cognitive domains, language processing or comprehension, praxis, the ability to do calculations, is not typical in patients with exacerbations of mood disorder or schizophrenia, is always present in patients with autoimmune encephalitis. And these other three categories of abnormalities that I discussed earlier that make you likely to have autoimmune encephalitis: new onset seizures, abnormal involuntary movements. They can be dystonia, dyskinesias of various kinds, tics, choreiform or athetoid movements, and sensory deficits. That can be peripheral neuropathy because a number of the autoimmune processes actually cause a peripheral nervous system abnormality as well as a central one. It can be visual field cuts. It can be distortions of smell or taste. So the presence of this constellation weighs heavily towards autoimmune encephalitis. The most important one is the presence of delirium. Jump back, sorry. So non-specific, very specific. I want to say a few more words about catatonia because this is a discussion I've had with a number of you over the past year. The issues come up again and again of, is catatonia a defined disease state? Is it a thing? Or is it a symptom of lots of things? And how do you define what catatonia is? This is a prominent textbook of psychiatry that was written about 20 years after, I think 18 years after the initial description of catatonia by Kalman. And in this, you don't need to read through all of this, but one thing I would just point out to you is that catatonia, by this definition, which was elaborated in the German psychiatric literature, included everything. I mean, patients who had the motoric abnormalities, but everything from patients who had seizures, fever, dementia, intermittent stupor or confusion, psychotic symptoms, and the outcome. So the determinations are in dementia, cure, or death. That's a pretty wide prognostic outcome. The patient either goes completely back to normal, or they die, or they have dementia syndrome. And the point I would make to you is that that group of patients that were described as catatonic likely included patients who had autoimmune encephalitis, brain tumors, strokes, and primary psychiatric disorders. And the spectrum of outcomes from complete cure to death reflects the fact it's not a uniform group of patients. But the label of catatonia sort of stuck with us for 130 years since it was first coined, and it's taken on this life as if it's a thing, as if it's a diagnosis. So I'm advocating to you, it's not a thing, it's not a diagnosis. It's the same as using the word psychosis or talking about delirium. You're capturing a group of motoric abnormalities in a patient that are significant and should be documented, but the differential is wide, and it ranges through organic diseases, which can be fatal, through treatable psychiatric disorders that might even spontaneously remit. And the fact that somebody is catatonic is notable, but not diagnostically helpful. That's important because, again, just to jump back to this slide, because you don't want to make the primary focus of treatment the catatonia. First of all, treating the catatonia is not going to have any impact on the underlying immunologic process, if indeed that is what's driving the catatonia, or even if it's a mood disorder or a schizophrenia spectrum disorder, loading people with benzodiazepines is not going to have much impact or get much traction on remediation of their psychosis. So think about that. Even when the catatonia is prominent, is what's the purpose in treating it? It is a diagnostic sign on exam, but it shouldn't be the primary focus of treatment. There's a more important issue, which is that, and just go forward. If you do medicate the patients to treat the catatonia, you're going to contaminate your ability to follow their delirium. Because if you load people up with 20 or 30 milligrams of Ativan a day, their cognitive exam is invalidated as a diagnostic tool. So you can track the progress of an autoimmune encephalitis by determining how cognitively impaired or intact the patient is. But if you're going to medicate them aggressively to the point that their cognition is offline, you've lost that index of clinical monitoring. And more importantly, if the delirium is the critical thing that you identify, that you argue to neurology and medicine to say this patient needs immunosuppressive therapy, and then you eliminate that as a visible sign because the patient's now unconscious in the ICU on 30 milligrams of Ativan, you then no longer have that mental status index that you can use to lobby for continued organic treatment. So I would just encourage people not to want to treat catatonia and to recognize it's diagnostically non-specific, but it is an important clinical finding, but it has a very broad differential. So what really matters is the presence of delirium. So for the junior residents, just make sure that you're confident in your ability to recognize and characterize what delirium is. That you have a template that you use for a cognitive exam, whether that's a mini mental or a MoCA or one of the delirium scales, and then you assess people for impaired consciousness and changes in attention, in orientation, in memory function, and other cognitive indices. One of the earliest manifestations of delirium is inattention. And I know you guys have sometimes seen people in the ER at 3 a.m. and you're probably pretty inattentive yourselves at 3 a.m. So when you interact with the patient and you can't remember what you asked or they didn't hear what you asked, it's easy to overlook that. You know, you ask the patient a question and you don't get a response. So you want to repeat the question and make it clearer. But be very careful of that. Recognize that not hearing or not responding appropriately to what you say is the earliest sign of delirium. Inattention is on that continuum all the way to impaired consciousness. It's the earliest sign. It's a subtle sign, but you should develop sensitivity for picking it up. The other thing that's important, because it's a waxing and waning presentation, is to do serial examination. So if you're not sure, examine the patient, go away, write your notes, see another case, and come back in 2 hours and repeat the exam and look at the nursing notes to see whether the nurses are documenting this fluctuation in level of arousal, motor activity, attentiveness of the patient. Very important not to miss this, because this might be the only index that you get that's positive. In other words, you could have an ambiguous CSF study, the imaging is negative, the patient won't lie still for the EEG, and you're not going to get the antibody test back for a month. But the presence of delirium is enough to hang your hat on that the patient's in the organic category, so it's really important. Serological testing for autoimmune encephalitis. So you can order a paraneoplastic antibody panel, it's the same thing. I hope that the vendors are going to start calling these diagnostic tests autoimmune antibody panels. The important things to know are that there are a bunch of common antibodies here, but this is perhaps this is perhaps 25% of the antibodies that we now recognize are associated with autoimmune encephalitis. So there's a lot of things that you're not going to get results on. CSF studies are preferable. So if you can get neurology to do a TAT, that is preferable. And many cases, including the one that I described to you, the CSF study was positive, but the serum study for the same antibody was negative. So just summarizing some of those nuggets in pursuit of diagnosis. These are pretty impaired patients. You're not going to get a good history from them. You might get a spectacular mental status exam, but you're going to need a collateral, and you're going to want to read the records and find out when the patient was last functional and how quickly they declined, and unlikely to get that history from the patient. Frequently, these patients are not cooperative. You know, in our case, our patient refused to take medication and was largely uncooperative. There was an EEG done early, but he wouldn't close his eyes, he wouldn't lie still, and he ultimately ripped the leads off. So this study was inconclusive. In order to assess for diffuse background slowing, you want the patient to have their eyes closed, and he would not close his eyes because he was paranoid. You obviously need people to consent to cooperate if they're going to have an EEG or high quality MRI. So those things can be derailed by the clinical presentation. It takes a long time to get the antibodies back. You know, the vendor says 3 weeks, but I've seen it take 6 weeks, and the patient's discharged by the time they get the test back. MRI and CSF is abnormal in some cases, but not all, and MRI is frequently normal or unremarkable. If you get a good quality EEG, what you're looking for is obviously epileptiform activity if the patient clinically looks like they're having ictal activity, and if not, diffuse background slowing, which is the hallmark of any encephalopathic or encephalitic process. The brain is diffusely abnormal in its physiology. However, I would bet that at least half the cases you'll see, you're going to make the diagnosis based on clinical grounds, and that's why the delirium assessment is so important, because that's enough to hang your hat and say this isn't schizophrenia, this isn't bipolar disorder, this patient is delirious. Going the wrong way. Yeah, treatment. Okay, so there are first line, second line, and third line agents to treat autoimmune encephalitis. These are therapies that you want neurology or medicine to prescribe. I'm not advocating that we write orders for steroids or rituximab, but this is a collaborative discussion with the neurology team or the medicine team where you say, clinically, this presentation is not consistent with schizophrenia or bipolar disorder. The patient is delirious, like patient has abnormalities in the history that are just not consistent with those conditions. We think we should have treatment for autoimmune encephalitis. So the first line treatments are fairly benign. You've got high dose steroids, IVIG, and plasmapheresis, the plasma exchange. None of those are going to be particularly dangerous or harmful to the patient. Certainly recognize there's concern about steroids and gastric bleeding, but compared to cyclophosphamide and rituximab, which are the definitive immunosuppressive therapies, these are fairly safe. So these are things that you can do before you get the antibodies back. You can do a trial, or you can do the steroids orally. IVIG is essentially pooled immunoglobulin from thousands of patients, and we don't quite understand how it works in autoimmune encephalitis, but a couple of theories are that either some of the antibodies bind other antibodies and get rid of the autoantibodies, or the presence of so many immunoglobulin molecules in the circulating blood blocks some of the immune cytokine activation pathways and just mitigates the autoimmune response. Either way, it works in some patients. And if you get a clinical response to immunosuppressive therapy, it tells you you're on the right track. And plasma exchange we talked about. The definitive treatment are these second-line immunomodulators. And rituximab has really been the game changer. All of the patients that I've seen that we've treated have responded to rituximab infusion. So this is a monoclonal antibody that kills B cells. So it basically shuts down antibody production in the index patient. You give it by infusion. We typically do the four treatments of 375 milligrams. You give them 1 week apart. The patients are immunosuppressed because they have lost their ability to make antibodies. Cyclophosphamide is a more aggressive therapy. It's an alkylating agent that inhibits cell division, so it inhibits lymphocyte proliferation. And then there are some newer therapies that are coming forward. We haven't been using intrathecal methotrexate. This monoclonal antibody is I think it's an interleukin-6 antagonist, and it blocks the inflammatory response. It's being trialed in everything from rheumatoid arthritis to CNS COVID infection and a bunch of situations where autoimmune or immune inflammatory responses are causing tissue damage. We haven't tried that either. And then maintenance therapy is typically steroids.
Dr. Williamson,
Yeah,
we've got to wrap up because someone
yeah,
else.
yeah, let's wrap up.
Thank you.
All right, so we'll go to, I'm going to give you the punchline on the vignette and then we'll wrap up. So we got our patient back from 7 West, behaving significantly better than he was when we sent him down the hallway, taking his valproate and his quetiapine. And he ultimately was discharged to outpatient follow-up with a resident and the neurology clinic. 2 years later, the patient showed up in the ER complaining of night sweats and a swelling in the neck. And on CT imaging and ENT workup turned out to have a large lymphoma with multiple lymph nodes positive extending from the mediastinum all the way up the neck chain. And he ended up having chemotherapy, several sets of chemotherapy, and made a full recovery. So this presentation with his NMD receptor encephalitis preceded tumor diagnosis by 2 years, and we had done a very aggressive workup for the tumor and didn't find it. We did everything from testicular ultrasound to whole body CT and PET scan, couldn't see it. And that is frequently the case. So last slide, the nuggets to take away. The last thing here, patients workup for occult malignancy, you should definitely do it, but recognize that the tumor may not declare itself. It may be microscopic and undetectable, and the patient should have follow-up to surveil for that. Only the most important thing I want to emphasize to you is this concept of psychosis, catatonia, and bizarre behavior frequently driving psychiatric consultation, non-specific. The presence of cognitive impairment in psychotic patients and or delirium is a very malignant sign, and that's the driver of thinking about organic disease processes and aggressive workup, and also consideration for empirical treatment for non-immune encephalitis. All these patients are delirious. All right, I'm going to stop talking at that point. Any pressing questions or comments?